everybody. Good afternoon. Welcome to In the Hot Seat. For our repeat viewers, thank you for joining us again. And for those new to the show, every 2 weeks, we put industry experts and our customers in the hot seat for a lively discussion, debate, and even some discourse as we humanize the digital experience. All aspects of the customer lifecycle are up for discussion, as well as the technologies used throughout each phase of the journey. And this episode, which I'm really excited about, is the first in our healthcare series and introduces all of the players that touch the healthcare experience. Michael, what do you think? We're live.
We are, and I think it's going to be a fun series. Actually, it's something we've been talking about for quite a while. Of course, you're the industry expert, not me, but I'm excited. I think it's a good topic that needs to be explored a good bit more. So.
Well, I think a lot of people don't think about healthcare when they think about a customer experience, right? And what jarred what caught my eye was a couple of weeks ago when the AMA won the CX award. I was just so excited about that. They were the CX Team of the Year by CX Today. And I think that just kind of goes to show that, you don't always think about it, but customer experience in healthcare, like where else is it more important to have a good customer experience?
Yeah, and that's a fun series. And I'm actually one of the judges for CX Today's awards. So
good job.
So thanks for plugging it. Yeah, no, but it is really interesting. And I think you're right. I think it's not something that people think of so much. I mean, and to be honest, some of the experiences that you kind of accepted for years and years, like, oh yeah, the appointment's at 2, but I probably won't see the doctor till 4. But I mean, whatever, it's important. And I think that people are finally becoming more aware that it is something that needs to be focused on. So
I agree. And I'm really excited today because I haven't been in a room with Lori forever. So this is going to be awesome.
Great. Well, why don't we bring her in and jump into some of the questions?
Great.
So Lori Logan, Chief Product and Growth Officer, NASCO, welcome. Lori has more than 30 years of experience in health as a healthcare executive. Lori's expertise includes a focus on healthcare product innovation, product management, strategy in healthcare, go-to-market strategies across both player and provider segments. Lori's held leadership positions at Athena Health, United Healthcare, Genia, subsidiary of Capital Blue Cross, Cigna, Trizetta, McKesson, Choice Linux Corporation. That's like every healthcare corporation I know. Her passion to improve and cure healthcare drives her talent to ensure seamless flow into the industry. Welcome.
Hey there. That makes me feel really old listening to all of that, but great to be here.
When your resume gets to be like 5 or 6 pages, it's just like,
it's time to give up.
I don't know. It means something. I'm not sure.
My work is not done yet. That's what I always think.
Yeah, exactly.
My work is not done.
Well, so Lori, let's talk about it a little bit. When we talk about customers, like Michael and I were talking about, right? We generally don't think healthcare. We think users, consumers. But when it comes to healthcare, who are the customers?
Yeah, I think it's a super interesting question. And I think like all businesses, and this has the human aspect to it, everybody kind of plays a role and everybody is a customer, whether it's an internal customer or an external customer. And predominantly, right, the consumer, the patient, the member, the person is the customer. And that's who we fundamentally are all here to support and to help, but we can't do that alone. So what I think of experience and customer, I think relationship, whether that's you directly with a customer or somebody else that you're helping in that. So I include everybody in that, and everybody's in it to try to to win it. So I think it is the patient, the consumer. I think it's the caregivers, the providers, the plans, the employer sponsors. It's everybody involved, because if any of that experience is fragmented or broken down, which we know it is, who ultimately suffers is the patient. So I think it's just a healthier perspective to look at all angles and consider everybody a customer, just like you do in your internal office or your family. Everybody's a customer, to you, with that. And I think that because of my really long background, and makes me feel old, but I think I have a different vantage point, right? I can see from a consumer lens. I've been a part of a consumer startup. I've been in the primary care office. I've been in the hospital space. I've been in the software provider and the payer in the back office. Everybody's really trying to help, right? You have to assume good intentions, and that starts with empathy, and that's really the heart of all that we do in CX, right? Is to make sure that we're empathizing for the other and really just assume good intent. So if you look at that lens, I think everybody's a customer in the cycle, because guess what? Everybody's human. Everybody's a person. At some point, You're all a customer of healthcare, with it.
Well, I'm more of a consumer, so I, obviously don't really know as much about healthcare as you two, but I just like to understand, and maybe the audience is in the same place. Who are the players in the healthcare experience, and then like who's responsible for the healthcare experience?
Yeah, so I think you've got your predominant players, patient, member, consumer. I'll keep always using those terms because depending on the vantage point, they mean different things to different people. You've got your medical staff and providers and clinicians. You've got your payer who's administering the business. They may or may not be paying for it because it could be the sponsor and the employer behind it who's paying for it, or the government for that. And those are your traditional players in this space. But I think as we've learned over the years, there's a lot more involved because of the human aspect. It's your care circle, it's your family, if you're elderly, it could be your social determinants of health, people that are helping with transportation and food deserts and stuff. All of that relates to your health, and everybody's involved in that. So I think it's easy to say it's provider, patient, and payer, but I think it's a lot broader, than that. And again, everybody is there to help the patient navigate the services, navigate the benefits, navigate their health, help them take care of themselves and leverage the system for that. But in the business cycle, you've got patient member who goes seek services, you've got the care provider of those services and who's administering the payment and who's ultimately on the hook for it, which could be the payer, but oftentimes it's the employer or the government as well.
So what role does a member, consumer, patient play in their own experience?
Yeah, I think an experience is the big word of it, right? It's really their life. Like healthcare is kind of their life. And I think, members, patients, consumers, they play a big role in that. My mother-in-law always reminds me, because she came from the generation before insurance existed, you were ultimately solely accountable for it, right? For the payment and everything with that. And I think with the advent of insurance, everybody realizes it's somebody else's responsibility. It's always somebody else's responsibility. At the end of the day, you need access to good clinicians who can give you advice and perform things for you, but ultimately you have to consent, you have to oblige, you have to be empowered for it, you have to take control of your health to the extent that you can with that. So I think it's up to the patient member to understand as much as they can and be an advocate for themselves. If they don't understand, ask questions. That's the hardest thing I think in healthcare is a lot of people don't understand. Be your own advocate, ask the questions. And if it's of a family member, of your payer, of your employer, of your doctor, keep asking the questions, because there are some answers out there. There's not answers to some of the clinical things that we deal with, but most of the experience is around the administrative side, and there is help and understand to be out there, but you have to ask the questions. So you have to take your own action. You have to be responsible for yourself, and that includes asking the questions to understand better.
And that's interesting, when you say caregiver, it's not just the provider, right? It's your daughter who's caring for her aging parent, or it's the son who's taking care of the affairs of the dad in the nursing home or whatever.
Well,
Everybody should be asking questions.
I think, Lori, that was a really important point, because I feel like a lot of people just sort of accept when they go into a medical situation, they don't ask enough questions, and they may get home and they feel like they had a bad experience, but they didn't take ownership themselves either. So it is kind of a balance there, right?
Yeah, I mean, my dad's a victim of a bad screening or a missed screening, with that, and he was afraid to ask back. And it's not that his doctor is going to say no, or even the payer is going to say no. They just didn't ask enough about it, right? To really dig into what was the questions and advocate for it. And generally, again, assume good intentions. You have to, the provider's trying to figure it out. Everybody's trying to figure it out, but keep asking, because nobody knows you better than you know you.
Well, and everybody has a different communication style too. And just because a nurse or a doctor or provider is not as communicative maybe as you'd like, maybe you have to help that too, right? That's a part of your role then, to enable that and help understand that you don't understand. Yeah, that makes a lot of sense. Well, so you mentioned member and you mentioned patient, and in my head, they sort of seem like the same thing, but maybe they're not. So, I mean, what's the difference, or is there?
Yeah, at the end of the day, it's the same person, but I think gosh, I've struggled in my career. Like, what's the right label? Is it patient? Is it member? Is it consumer? None of them are all encompassing. And I think it's probably okay to have different terms because your role with them kind of takes on a little bit of a different vantage point. But ultimately, at the end of the day, they're humans, right? And but the experience is a little bit different. I think when you think member, you think more around servicing and administrative, and the relationship is along those lines. It's not as much on the clinical sense. As soon as you hit to patient, everything changes. One, you assume that the caregiver, the provider, the whoever that is, usually you're dealing with a clinician, has a different sense of caring for you. So your expectation as a patient is you expect them to be more caring. Doesn't mean you shouldn't expect that by being a member too, but it is what a human perceives that. And as a provider, I tend to be a little bit different in that as well. If I consider them a member versus a patient, it's kind of a hard, line with that. And I think there's also different, when you think of a member, you may not know everything about me. When I think of me as a patient, I think you know way a lot more about me, right? So there's a different, I think, wall that gets put up as well too. So at the end of the day, they're all human though, and it's what is your role to help them and help them navigate through whatever circumstance it is. Usually, you're not interacting, certainly from like a plan perspective, where you see member more often. You're not usually interacting with them much because it's a good thing, right? There's probably some service that happen, with that, but it doesn't mean the same rules of empathy, caring, and all that shouldn't apply with that. But so I think you just have to use it in the right context, in the right situation. But at the end of the day, it's one person, and it's that one person that carries that experience in all those scenarios too.
Yeah, that makes sense. I mean, it's more of a role. So I'm in the member role at the time, or I'm in a patient role. But yeah, okay, that makes a lot of sense. So we talk a lot on the show about customer experience, and we said that before. But one of the things that's been a big trend over the last few years is giving customers a self-service experience, so they can interact at any time, anywhere, based on their own needs. Are people more likely to want a low touch or a high touch experience in healthcare?
Yeah, I think it's a good question, and I don't think there's one universal answer. I think you have to meet people where they are, and probably depends on the circumstance. But and it's interesting you say high touch versus low touch. I think low touch, if you're thinking chat or something like that, can actually be high touch because I can get the frequency of the communication pretty rapidly and quickly. And for me, I like that, right? I'm definitely a chat and an email person because I also multitask a lot and I can get multiple things done. If I have to pick up the phone, it's hard for me. It's going to take me weeks to do that. What's interesting though, my mom is the same way. Now, chat's too much for her, but text, right? Text where she can think about it, understand it. She's hard of hearing. So she can read the words and understand the words and contemplate them and doing that too. However, if it gets to be a bigger issue that needs a discussion, then she's going to need a discussion. But interesting, even with that, she still likes documentation. If it's about a condition or something, send me something I can read. So I think it's a high touch, low touch, but it's also being able to see some people like to see words on a page as well as hear them through a piece so they can refer back to it and reinforce too. So I think everybody's a little bit different. I think they have a different tipping scale of what they're comfortable with and what they do electronically versus they need a face-to-face human, dialogue with it. And I think we should open up everything. At the end of the day, everything has a written word to it, and we should enable more of that and let people just choose their preference. What do I feel most comfortable with? And then make sure I opt out. I don't want to get stuck in a chat cycle where I can't opt out and be like, just pick up the phone.
Yeah, I think, I agree. I think that's an interesting one for me personally. I'm the same way. I like to either interact online, email or chat or text or something. And a lot of it is because it's asynchronous, right? I don't have to take the amount of time it takes to pay attention to the phone call. I can schedule my appointment. I can ask questions, whatever. I particularly like that. So that makes a lot of sense. So who do we consider like most influential in the healthcare experience from a patient perspective, member perspective, provider perspective?
Yeah, I don't know that there's a most. I think there's different roles, and I think here's what you can definitely do. You can figure out who can compromise that relationship the most by messing up, right? By not getting things done. So sometimes a bad experience overweighs like the good experience, right? With that. And that tends to be more on the administrative side of things, payment and billing and, that piece of it. So I think that tends to taint it. If you think about influential from a trust perspective, I think that's a whole different kind of ball game, right? And who you have that trust with. And it may or may not be your doctor. It may be more of your care, who's in your care circle, your son or your daughter, like you mentioned, Kristy, or your spouse or your whoever, or it could be that physician, or it could be the nurse, because the nurse has better, communication skills, with that. But I think as far as influential, it depends on what you mean. If it's influential to help me understand the system so I can maybe go seek the best care, probably going to take it for whoever makes it easier for me to understand. And the role doesn't matter. Like, help point me in a direction. Just who's going to help me the most and make it the most easy to understand, and make sure that I don't get, something that happens in the back end from it. But I think about the servicing side of it versus the clinical side of it is very different influences, right? On that. And healthcare is probably a good split of both, right? You've got the human side of you and the health clinical side, and then you've got the whole administrative, like how do I get to that as well. So I think everybody, it depends on the person. I don't think there's not a clear answer. I think we've always said, like, is it the payer's role or the provider's role? Who's got the most trust? I think it depends on the situation and the role of that aspect, right? Like, I don't think the payer is going to be the one that's going to be the clinical guidance of everything. That's why we were empowering providers more to do that and to be able to afford, to do that. But they do impact and influence a lot of their healthcare decisions, right? And as well too, and especially around navigation. I think navigation is the biggest challenge that everybody has today. What do I have for benefits? Who do I see for what issue? How do I get to them? Do I have to? What are the rules of the rule? What do I have to pay for? What do they pay for? When I call them and they say, do you accept my insurance? Is that all that's involved, or is there something else going on? So that the navigation, to me, then, if you said, like, who's the most influential, it's probably who helps me navigate the easiest with that, and is my support partner.
That makes sense. It's a very complicated system too, or it seems that way from a patient perspective anyway. So.
Well, it is complicated. I mean, we've had those discussions, especially with Thomas and Ralph, right, on with the German experience, where healthcare is easier for them, and over here, to them it's just so confusing. And it's interesting, because I wonder if all of this has spurred the advent of the geriatric care manager, the law offices that have those people that help you not just navigate appointments and stuff like that, but they're figuring out your benefits for you, because it is so complicated.
Yeah, it's complicated, and the healthcare world is still largely built on a model that doesn't sponsor or advise for navigation of care to do the right thing. It's still based on volume, and that's shifting. Economic models are shifting, but the model is to just go to the visit, not necessarily navigate to the right path. And that's why you see the more of those advocates, care managers, care coordinators, care circles, that piece to help navigate that path. That switch to navigation is a big shift for us, because the economic thrust underneath wasn't there for that.
Right. I know when we worked together, one of the things that we started out with there that I really was all in on, right, was the ability for the entire care circle to communicate, because that's really hard to have, 4 doctors in different systems communicate with one another, and the daughter that's taken them to the appointments, and, the specialist, and all of that communication isn't seamless or easy. And I know it's frustrating for me when I go into a doctor's office and they say, okay, so what meds are you on? Can you not see my chart? Like, seriously, I do go in there and update it. Can you not see it? Oh, no, we don't use that.
Yeah.
So it is hard to discuss. Oh, go ahead. Sorry.
I was
just going to say, it's hard to discuss CX these days. Oh, I think there's a lag on my part. Sorry, I'm obviously having some internet issues right now.
And I thought I'd be the one. Yeah, I think the care pathways are hard to navigate. What you can do, and I don't think that's going to get easy anytime soon. However, the things that we do know, the things that are in the data and the records and stuff that can be exposed and help that, more will be. I think some of that is experience, but a lot of that's just the economics. As you see the economics change to how providers are paid, and they can afford, again, assume good intentions, they can afford to have those clinical navigators in their place, call them a care manager, a care coordinator. That's what's really going to help with that. And I do think that's where on the provider side, they're going to be able to balance that better than a payer side because they understand the clinical pathway there and the coordination amongst the providers and stuff. So that's going to have to happen in addition to the technology, because you could expose all that technology to me as a patient or my spouse or my son, and they're not going to be able to understand it either. So I think you still need that, especially when you get into more complex areas, you're going to need that clinical guidance and navigation. And that's where we need to empower our providers to be able to run a business more like a care team and a circle there to help with that as well. So it'll come, but it's a different clinical pathway.
Is that part of the whole value-based care model? Is that where that's going?
It is. And I think where you've seen, who knew we get into value-based care and we're talking about experience, right? But economics run everything, right? And the economics underpinnings drives behavior and who interacts with who. And that's where it comes in. And what you've seen is it started out, kind of 15 years ago with value-based care was more the hospitals and the hospitals, it's great. There's a lot of cost to be taken out, and that's what they did. But what they didn't do is empower the primary care physician, right? So if you want to change the course of care, you have to empower the relationship with the primary care physician and the patient, to do that, to get things before they happen, not just make them cheaper when they do. And so a lot of movement and innovation, quite honestly, you've seen, especially going into COVID, was around primary care and empowering the primary care, physicians. The challenge is that there's still a primary care crisis because of low reimbursement, because of the high administrative burden, because of all those things. But the more we can empower up primary care and pay them adequately for it, the more that cycle is going to turn, because that's really what they are, the navigator of your care, right? That's the old GP concept still holds true, in that fashion. So the payment models are getting there, the economics are getting there, but they're struggling with the current world, and the experience of the current world is preventing them from, going to that future state. So it is all about the experience, but that's a big shift from improvements.
And, it's hard to talk about it without talking about AI and personalization these days, right? I know this is one of Michael's favorite topics.
Oh, yeah.
So in a regular consumer relationship, right, there's some sensitivity to privacy and data security, but in healthcare, you've got HIPAA and you've got all of the guardians and all of the standards, and it's even more important and regulated. So is personalization of interest in the patient relationship? And if it is, how do you balance the need for personalization and protection with privacy?
Yeah, I think I'm going to take it from a member lens on this one. So this is where it's good to kind of differentiate like the patient and the member. And I'll speak more from a payer side, because I think at first in healthcare, we have to start with things that are less concerning or private and there's a lot of room for improvement in the overall experience. And I think that's a great place for AI, and specifically Gen AI, to help in doing that. And but to your point, in healthcare, we have to be super careful of responsible use, and it's very new, and we need to learn from it. So we spend at NASCO, obviously in a technology company, we spend a lot of time thinking about this and acting on this. Very proactive management of privacy, intellectual property, ethics, cybersecurity risks, human-centered design, and when to use it, when not to use it, and all of your tooling that you have. And then it has to be guided. And I'm sure you guys have heard of the term human in the loop. Like, you can't just let this go, right, and go on its own. It has to be curated, it has to be leveraged, and it has to have governance around it as we gain comfort with it. So for us, like where we're starting is in areas where we can don't have to dive as much into the personal privacy, helping to understand consumer questions in an easier way, right? Using things, GPT, to make sure that we understand the actual questions that's happened, that maybe not be codified in a CRM system, like what's really the question that they're asking. And then we create a lot of data that we can learn from that and ultimately get to some root causes of the experience. But so I think for for us, the way that we look at it, I think it's another technology in our toolkit. We're going to use it to, and I think this can apply universally, use it for maybe some non-essential tasks and automate those things so we can free up our teams to do the higher needed work. So if you think about customer service agents, right, at a plan, and when we talk about experience, making their life easier, making them better able to interact with members at this point, I'll call them members, is where we think there's a great use for it. And then eventually into the self-service area too. But there's definitely a line, I think, from a service perspective into more things that are clinical. When I think when you get to the clinical place and you're giving advisement on what to do next from a health perspective, I think that hits a different realm, and I'll leave that for the clinicians to decide. But I think we definitely see a lot of use to, when we say personalize the experience, I think it's to understand the human dialogue better so that we can actually answer their question in a more efficient way and interact with them on that, not to advise and take a different path on their health pathway, but to help them understand the situation. And then we'll continue to learn, from it.
I mean, one thing we didn't really ask about this, but we've had a lot of discussion lately around communities and how businesses can use them. And so it just kind of brings up another thought there for me. I wonder, like in healthcare, is there a role for community in this as well? So is there something there that can help improve the experience?
For community in general, are you saying, or so totally separate from the AI topic? Is that?
I mean, totally separate from AI, I guess, but I mean, I suppose there is always some role that AI helps you, mine through data and that sort of thing. So maybe there is some use, but I was just kind of thinking about community in general. Is there a role there? I mean, obviously HIPAA and regulations play into that as well, but
Yeah, I think there's, if you've ever heard the term population health, it's about the population in a community, right?
yeah.
And that the community is part of your health with that. And I think we see, especially with the baby boom and the rising Medicare population and the elderly, and some of the biggest issues are that contribute to negative health consequences are things like food deserts, transportation, and those are more community-based programs and community-based avenues. The challenge is finding those programs and benefits per se to help patients, members, consumer people, humans find access to them. But there absolutely is, because that's the stuff that healthcare is local and can only be helped local. You can't change all that through technology and through remote, call centers. It has to be something that's community led, because that's where healthcare happens. With that, I do think what you start to see a little bit is connectivity, like from the hospitals and the health systems, to make sure that they're working with those programs, and payers starting to do that too, and providing benefits for Lyft and things like that too. But I think that's a great place where you see community happening is transportation and food as well from that. And I think what you don't see necessarily as much in the healthcare, because we always think of like insurance and payment, is just a sense of community and social well-being, right? And which is critical to everybody's health. And I think the more people, and certainly the pandemic showed it, isolation's not a good thing, right? So I think community services in that sense too, food, diet, transportation things, but just community services themselves to make sure that people have human connection is a big part of health.
And I would think it also could be a big part of helping people with certain specific kinds of chronic illness or whatever, maybe support each other some too, or is that something that doesn't happen?
No, it definitely can. I think, where I think there's some good hope for that too, is there's a lot of new clinical programs coming out that are more condition specific as well. And then when you deal with a certain patient population, you have an opportunity to create a patient community as well too, whether it's musculoskeletal, different, unique cancer and stuff as well too. But where you can find like patients, there's always that, I think, sense of community, somebody like me that happens. So I think you're going to continue to see some of this is spawned from what we were talking about earlier, Kristy, with value-based care. You see a lot new clinical innovation coming with condition-specific thing. And I think they understand that population more and their whole needs of it. And you'll start to see more unique community things come out of those clinical programs, because they really are, it's all about the whole person.
Mm. Yeah, that makes sense. Well, so the word advocacy I hear a lot when we talk about, I don't know, patient-centric healthcare or healthcare delivery. How does that play in, improving the patient experience?
Yeah, we talked about this a little bit before. I think advocacy is huge. You've got to be your own advocate, and everybody has to
Right.
help for the patient to advocate. And yeah, I think that the biggest piece is to understand more what your options are. It, I'm trying to relate this back to the experience, but it's really to understanding what's right for me. How can everybody understand what's right for me and it's going to help me? And I think the more that we learn those pieces that are more on the human side of
Mhm.
healthcare versus just the clinical side of healthcare, we're going to get smarter about how we interact with members, patients, consumers to help them navigate easier. So one of the good things about AI is that you create more data with customer interactions, and more data is gold, right? The more data you have, the more you can see patterns. And what we don't have good data on in healthcare is customer engagement, right? What does it really mean to be engaged in healthcare? So hopefully, as we start to employ new technology, we can create new data and look at the different types of patterns of human behavior as it relates to healthcare, not just the doctor-patient visit, which is mostly what it's on now, because that's what we get paid
Right.
for. But I know I've been after consumer engagement for a long time, and there's just no data to collect. We're still trying to capture care management data, right? What happens between the nurse and the patient that isn't,
Mhm.
charted on a claim, and how do we get that information? So hopefully, as we start to understand more of these interactions, and we can put in things to assist those interactions, not drive those interactions autonomously with things like Gen AI, but assist in those and create new data, learn new things. We'll learn more about the human behavior side of healthcare,
Mhm.
and then I think that's where we'll make some bigger gains with
Mhm.
it. So advocacy to me is like the core of that: asking the questions, getting the answers, understanding that putting all this stuff in a library for us to learn from on that human engagement side
Mm.
as
I, I
well.
just I just spent a couple of weeks visiting my mom, and she'll be 89 this week actually. And one of the things I've seen with her care is really trying to coordinate everything.
Yeah.
And and it seems like that's really, and she's still very sharp. I mean, mentally and all. It's not that. It's just that there's so much stuff and so many different providers and conflicts sometimes about, oh, this medicine doesn't go with this thing or whatever. I mean, how do we improve that for people? Is that advocacy as well?
Yeah, it's advocacy, navigation, and I think it's the clinical pathways for certain people, and
Mm,
especially as you get older, that need for care
mm,
coordination and navigation increases. I think that's where you've seen a lot of innovation in the Medicare space, because that need is so high, and getting that right actually curbs costs. So there's always going to be a costier piece of it, but it's proven, right? And a lot of
mm,
there's your chem meds and there's different primary care models that are focused solely. Now, largely what they've added into their clinical pathways was care coordination and care
mm,
management.
Mhm.
It's not so much
mm,
different procedures or different drugs or different things. It's really helping them navigate the best path for them. So I think
mm,
that shows us that care navigation piece is a critical role. It
yeah.
is what gets you back to value-based care. It's equipping the primary care. That's what primary care providers would love to do and would like to do more. They have to be able to afford to do it. And so you start to see more care management and um, non-senior services as well too. But that really is the function of care management. In the past, that was always done by the payer, but with lackluster results because they weren't close enough to the clinical teams stuff to do that. So having that on the provider teams will help, but we got to
Mm,
make sure the providers can afford to do that. They can't just add new nurses to do that function without being able to get paid for it. And they can't see 20 patients a day, to be able to do that. So it does get back to the finances, of it, unfortunately. But that's how we get insurance, right? Is to be able to, to do that. But advocacy and that care coordination, to me, it comes hand in glove. And who's best equipped
mm,
to do that? I do, and I think everybody needs to know it. So the payer needs to know it. But I think a lot of the provider teams need to know it. But certainly in those situations, and especially as you get to elderly, their care circle, who's helping them navigate that? Their son,
mm,
daughter, spouse, cousin, wife, neighbor, with that as well.
mm, yeah.
So, Lori, when we were talking about Gen AI and you started talking about engagement, do you think that Gen AI is going to be most helpful in the member patient space, or do you think, like, do you see a day when providers start relying on AI for diagnosis?
Yeah, I couldn't speak to that. I'm not clinically trained, and having worked with physicians for majority of my 30 plus years and things, I make sure not to cross that line. I think what you could see at a minimum is providing more personalized information to the provider to make decisions and help interact with their patients, in different ways that's more efficient with that. Whether it gets down the path of diagnosing, I'm sure there's going to be clinical ways that that's going to help with that, but I wouldn't want to emphasize on that. But I think there's so much room to help on the servicing side of things and navigation and understanding these pieces that that I think is a no-brainer, right? It doesn't get into as much of a risk of a concern of like a bias or an unethical use or things like that, right?
Right.
That's where you get concerned on the clinical side. But again, I'll let more of the clinical teams do that. But I think there's so much we could do to help with their experience. They could actually focus on that more. Right. When you look at physician burnout, I was actually just reading a stat today. It's still staggering to me, right? We continue to have less and less primary care physicians, reimbursement issues, payment issues, but also they're just burnt out because they're spending, I saw a stat, 2 hours for every hour they spend with patients. That can certainly be attacked without getting into places that get borderline sensitive. There's a lot of opportunity to correct that. Let the physicians do what they want to do and what they're trained to do and what they do best and provide the care and the clinical guidance. But
it's sad we're still talking about burnout because we've been talking about that since before the pandemic. And I can't imagine how much since the pandemic that's gotten worse.
Yeah. If you think about anybody that's in a business workforce and what you guys do every day, right? I think you can remember we used to have the opportunity for like locker breaks. I'm going to walk across the hall to get to the other meeting room and then have a chance to like breathe and grab water in time. We now have gotten meetings down to like 25 minutes. So you can add 3 meetings into the hour instead of like 2 with that too. So I think that's the path that clinicians were always on, but now we've introduced added channels to them. Now they're having to respond more to messages and to teleappointments and everything too. So the burden has definitely, I think, hasn't gone down.
That's interesting.
Yeah, I'm curious about something with Gen AI because obviously one of the things it's really good at is giving you a natural way to interact with large data sets. And I remember a few years ago, I was talking to a provider client and about some of their healthcare stuff, and they were talking about how useful having this massive data set for physicians could really be to isolate and find out and help with diagnosis in different ways that perhaps we've not been able to do in the past. So I was just curious, is that something that that people are looking at today? Is Gen AI one way to help kind of share a global data set and perhaps improve diagnosis across, all those different boundaries?
Yeah, I don't know if I'm the best equipped to answer that, but what I would say where there's more data, you can analyze the better, right, to get to different diagnoses. I think what's still missing is creating data around engagement to see what do you do with them, right? So certainly you can get the data around diagnoses and procedures, right? That's in our clinical data sets and the results of that. So that'll be good. So certainly there's going to be a lot of opportunity to dive deep into that meld of it. The sharing of data, again, that's going to be another one that's going to be baby steps, to get to, to whether there'll be one mass pool of data, but a lot of that you can do anonymized as well, right? And figure out to do that. So I think there's a tremendous opportunity for both better diagnosing, but also understanding, creating a whole new set of evidence-based care, right? And what that is, more data, more evidence-based, more physicians like that, right? Because there's data behind it. Physicians are very data, hungry in their evaluations. So I think there's definitely, from a clinical perspective, lots of opportunities, for that.
Seems like there would the whole social determinant space would be rich for AI, right?
Yeah.
I mean, you can almost get that information yourself now just by Googling.
Yeah.
Where's the nearest doctor to this location?
Yep. And again, you could look at patterns, right, and predict who's applicable or not and keep it anonymized. But yeah, I think there's but it definitely needs lots of data and it needs access to lots of data to get there. So I think the social and behavioral side that's going to open up and unleash new opportunities with that. Not so much in the clinical records are still going to be under, rightfully so, lots of protection, but there is lots more data out there too. That's what we've always talked about, consumerizing healthcare. when you can go into your grocery store and get the right, your recommendations, and you can't do that in healthcare because they have behavioral patterns, right? What they're actually called were behavioral purchasing patterns, not what we typically get in healthcare yet, but more tooling added too, right? There's more apps out there. There's more things out there. There's more clinical engagement programs. So as that engagement programs creep up, that's the new data we need as well to go with the existing data. We can't rely on, in healthcare, I think we've always relied on the claim and the clinical record to tell us everything. And there's more out there that we've got to incorporate into it to get that.
Yeah, I mean, you think even grocery stores, you go to a grocery store these days, they all have pharmacies in them.
Yeah.
Yep.
It just seems like rich.
Yeah. Well, so we talked a lot about experience, and let's shift to the word engagement for a bit, because I think that's important too. And I'm just curious, like, what are the best ways to foster engagement, across the system, other than just like how to navigate the system? And then is there a difference for, medical adherence versus like following up on diagnoses?
So there's a lot in that. I think the interaction, so medical adherence, for example, we should be able to track better who is, who isn't, why they aren't, and how to intervene with that, right? Because it's talk about purchasing patterns, right, at your pharmacy and stuff, and that's one. I think that's one element of engagement. I think the other is just I've often used like lowercase engagement and high, capital E versus lower E with that. Higher E is all the things that I do from my health, diet, fitness, as well as my interaction with the more clinical, medical system as well. So it would be great when there's a day that those consumer behavioral patterns can come into the medical clinical patterns for us to really look at that data together and get that. And to me, that'll be engagement, right? Engagement takes knowledge, empowerment, not just on how to navigate the benefits of which hospital I can go to and which provider I can see, but empowering me for health, with that. So the day that those can both come together will be an interesting kind of chasm of that. But to me, I think capital engagement is everything I do for myself that impacts my health, as well as my interaction into the medical system too, which is where we tend to focus more on today.
Yeah. I'm wondering, even like with apps, like, I log my food in MyFitnessPal, and I have a scale app, and I have a pedometer app. Like, it would be so useful if all of that data would feed to my provider. So when I get there and she looks at it and she goes, oh, for the last 2 weeks, you've only eaten 1,200 calories. You really need to eat 1,600 a day.
Yeah.
Oh.
Yeah. Yeah. I think that day will come. I'm going to be the broken record. We have to make sure that our providers, one, can get access to the data, but we could enable that, I think, but two, have time to react to it and help and use it to advise with it, right? And make sure you may not need a physician for that. You need a nurse to do that, right? Or who's the health coach, of that too. So I think when you can start to enable the provider teams to have more of that multidisciplinary, that's when it'll really take off. If you have to always rely on a physician, well, we just said we have a shortage of them, right? But there's other people in the clinical teams and the care teams that can play that role and help with that too. I worked in one of my experiences with a company that focused a lot on just that. But that's a lot of what they ran into, is because they were working with smaller primary care offices who didn't have the other people to help, with that health coaching kind of piece to it. But I do think there'll be a point when people get more comfortable with their data, that they're willing to share it more if they see the value in it. And what would it do for me? I'd share it right now, right? If somebody could give me the program, right? Do it, but I'm super comfortable with that too. So I think as data becomes more comfortable and AI becomes more of a tool for me and comfort with it, but there's a lot of protections I got to be put into place first. But even just sharing that information would be helpful, for that.
There's so many sensors. Yeah. So many sensors now that we can wear. I just had one of these rings, like it captures all kinds of data that I would have never thought, but very interesting. And it would be useful if I could share that. So that's cool. Well, that's all the time we have today, actually. And I could keep going, certainly. But anyway, Lori, you survived the hot seat. And for the audience, if you think you have what it takes to be in the hot seat, let us know. We'd love to hear from you. And that's your In the Hot Seat episode for today. Thanks so much for being with us this week. I'm Michael Fauscette.
And I'm Kristy Tupper. Tune in next time for different faces, different topics, and different perspectives as we put somebody else in the hot seat.